Manish, if you want to get up there. Martin, I think Chuck obviously is not going to join. And Sig, I think, took off already.
Yeah.
You got to leave too. Okay. Well, the experts, yeah. And Mo, do you want to present? Yeah.
So, thank you for that great day today. It was really informative. So the case I'm presenting is sacral fractures below prior instrumentation requiring S1 PSO. So 68-year-old female with prior fusion at L3 to S1 for degenerative scoliosis. She's been reporting pain since 2014 when she slipped and fell on her buttock, sustained a fracture in her sacrum. Since her fall, she's been having burning pain to her lower back. She thinks that she's been starting to lean off to her right side even before the fall. As I mentioned, she had a previous L3 to S1 posterior spinal fusion for spondylolisthesis at L3-4 and L5-S1 in 2015. That was at an outside hospital. She was referred to UCSF. She was very displeased with her posture, and this is affecting her quality of life. She says it kind of makes her feel shorter. And then prior to her surgery, she's unhappy, cannot walk her dog, her grandchildren. She's having a hard time maintaining her posture, causing her to take deep breaths to do that. Overall, she's also complaining of perianal numbness. She's tried physiotherapy, uses a walker, cane to ambulate, and requiring fentanyl patch for managing her pain. And then other than that, she also has a T-score of negative 2.1. Yeah. So these are her initial films, AP and lateral, and you can see in the films here some of the pathology. This is 6 months when she presented to UCSF. And this is kind of zoomed in. So there's like the fracture distal to the S1 there. This is a CT scan. Overall, this is her alignments. So C7 S1 SVA is 24 centimeter, L1 to S1, lumbar lordosis is 68, PI 90 degrees, L5 incidence 84 degrees. How would you manage this?
Can you go back to the CAT scan?
Absolutely.
From here, is the fracture healed already, or?
It is, because it's been a while. Yeah.
It looks healed. Okay. So you have a high PI and a kyphotic lumbosacral junction, which is really a bad combination. So it's a bad combination having a very high PI with a lumbosacral kyphosis. So I think this is ideal, as the title said, for an S1 PSO. So, and then I guess if you want, I wrote a paper, a case report, which really well illustrated if anybody wants to see it. I think it's in the European Spine Journal, kind of with nice pictures on how to do it.
Yeah, I've read that. I would also support checking that out. It's very well done. Mo, can you go back to the first post-op x-ray? I think this is a good learning case. So this is a patient who has 3-to-1 posterior instrumentation, and she has, so that's on the verge of, does she need pelvic fixation or does she not? Sig's talked about above L3, putting extra stress on the S1 screws, but then he talked about other patients who would benefit from pelvic fixation. Those are those with high pelvic incidence, a priori. It looks like she has probably a unreduced L5-S1 isthmic spondy there in the setting of a high PI. She probably, we don't know, but maybe she's overweight and she's not osteoporotic, but her bone quality is not ideal. So all those things into consideration, stopping at S1 risks a distal junctional issue. So either a non-union or a fracture like this. In the sacrum, the worst bone quality is in the sacral ala, and that's where the screws start, and they aim medial, but usually it's a fracture bilaterally, and then you can have a concomitant transverse component, which leads to a U-type sacral fracture. it's ideal to get to these sooner than later, but once it gets to this point where it is a united kyphotic deformity, then doing a S1 PSO is needed. The easier thing to do would be to do it higher up, like L4. You see she has a spondy at 4-5 that's not reduced, so that's also contributing to her flat back. But I think the tenets of deformity surgery are address the deformity at its apex. If you do something higher up, you're not addressing what's distal, and this is the lady that you may correct her sagittal plane, quote unquote, adequately, but you're going to have a lot of cantilever forces still on the pelvic screws that you put in. And this is the one that may have the tulip heads pop off, the set screws pop off. So you have to address the deformity at its apex.
Having said that, though, I think it's really important that you know that you can achieve distal fixation before you're going to do an S1 PSO. Because if you can't get good distal fixation, then I would highly recommend not doing the S1 PSO because you're kind of screwed. And then if you're not comfortable doing an S1 PSO, I don't think you'll go to jail doing an L5 or an L4. So I think we like to fix it at deformity, but you have to work with, if you do a beautiful S1 PSO and they have a drop foot after, they're not going to be as happy as if you felt more comfortable doing an L4. So I would say, I would pick, ideally, I do try to go for where the deformity is, but I think you have to work as safe as possible for the best outcome for your patient. So.
I was wondering, given that she's having some cauda-like symptoms, would fixing the deformity above where it is most acutely deformed would the decompression obviously help resolve that or prevent it from progressing?
You can decompress everything as well. So, like you'll study your imaging and decompress what needs to be decompressed.
Okay.
Yeah, I think the decompression is super important. It reminds me of a high-grade spondy. The high-grade spondy with lumbosacral kyphosis, this is a typical appearance. So you have to decompress, and then you have to fix the lumbosacral kyphosis. So the good news is, the bad news is they didn't use iliac fixation. The good news, they didn't use iliac fixation. So you got lots and lots of good tracks to put at least 4 S2AI or iliac, whatever you want. And then this one, you can't just have 2 screws. You have to have 4, and then do the PSO. And I use the table, so I'm not cranking on the screws. That helps a lot, because if you crank on the screws, sometimes they splay inside the bone. So I use the ProAxis table, which helps. It's an expensive table, but I've done them before where you just have to push down. So either way. But I think having good distal fixation, good decompression, wide decompression, really lay out the nerves before you start taking bone and destabilizing it. Then the nerves disappear, and then you're in trouble.
The key also is take out the whole sacral ala too and follow the 5 root. Do a 4-5 decompression, follow your 5 root from the top down, and then follow your S1 the same way. And you have to actually, the distal part of the foramen is the sacral ala. So just like when you do a PSO, at a different level, you take the pedicle out, so you make one foramen. The sacral ala is your distal pedicle, really, that you have to get out along with the pedicle of S1.
Yesterday, I was moderating a AAOS webinar on sacral fractures, and it was a combination of spine surgeons and trauma surgeons. And the trauma surgeons are now more in tune with the sagittal plane deformity. So when they have kyphotic sacral fractures that are acute, they are doing their best to reduce them and get them realigned to prevent a situation like this. So it is but if they don't fix it, you could end up with a similar situation.
Yeah, interesting talking points. Actually, this is exactly what was done in this case. Every single point has been touched on. So I'll kind of summarize what happened. So they basically revised the segmental fixation from L3, 4, 5. They placed bilateral pelvic fixations using Galveston technique for the iliac screws. That was been popularized in 1980s, as well as bilateral sacroiliac fixation for supplemental pelvic fixation based on the Sponseller Kabesh technique in 2007. And then they went on with fixation above and below the S1 fracture, and then performed a wide decompression, exactly as we've heard, for the neural elements, and then specifically revision of the laminectomy of L5, S1, extended the laminectomy of 2S1, and then performed the posterior base osteotomy of S1 through the prior fracture. And the osteotomy incorporated the sacral ala into the SI joint to disarticulate the sacrum from the ilium. And then following that, significant correction was obtained to the S1 fracture, but it wasn't adequate, incomplete. So when they went on to with the pedicle subtraction osteotomy, as we discussed, specifically they performed the posterior base osteotomy, Smith-Pearson osteotomy, to the incomplete fusion, and then performed the posterior base extension of the S1 pedicles bilaterally with a 3-column wedge resection of S1. And then for the correction, they used cantilever technique with a 6mm cobalt chrome rod, rotated the pelvis to reduce the pelvic tilt, and then extension of the legs to assist with the correction. And then they went on to fixing the rod into these segments. And then they used local bone for fusion. They did encounter a dual tail, but that was repaired. And this is how it looks like.
I think it looks like you fixed the coronal plane as well. You see that? So, spondylolisthesis, if you look at them really carefully, they're never like straightforward. They always have a little rotation, right or left. So this was what happened here.
That looks great. Congrats.
All right, thanks, Mo.
Thank you.
Anu, I can present it. It's okay. Okay, we'll do the next one. And this is a gentleman who is a professor at Berkeley, 71-year-old male, presents with back and leg pain, chronic back pain over 4 years, and disabled by his back pain and leg pain, has failed non-operative management. The major focus here is his abdominal surgical history, is a history of Crohn's disease, and I'll show you his pretty extensive surgical history. So he has a form of it that causes a lot of strictures, and he's undergone more than 5 operations for recurrent small bowel obstructions, strictures, et cetera. And as you can see here, multiple revisions of his jejunal anastomosis, the most recent one being back in 2019. So if you look at his abdomen, you can see all the history of that. So anyways, he presented initially to me with a de novo deformity. I recommended an operation, asymmetric PSO, reconstruction of the coronal and sagittal plane. He didn't like that, so he went to Stanford, and they recommended an MIS decompression and this MIS TLIF. And then within a year, his coronal plane decompensated even further, and his sagittal plane got worse. So he came back to me, and I told him I'd be happy to help. So looking at his imaging, he's got a pretty significant coronal plane deformity to the right. Sagittally, he's not as significantly off. If you look at the supine, he does have that autofusion of the L4-5 disc space from the osteophyte on the right. And then looking at the MRI of his lumbar spine, you can see the decompression's done from the right side. The L2-3 segment looks persistently stenotic, and but the rest of it looks open. If you look at the CT scan at L5-S1, the TLIF cage placed from the right, when you see black, or that's usually a sign that there's motion within the disc. And if you look at the posterior lateral space, the transverse processes of L5 to the sacral ala have no bone. So all the fusion was attempted to be done through the interbody space, but did not achieve it. There's no gross loosening of the L5 screws, but you can see some subtle haloing around the S1 pedicle screws. Sometimes when you have non-unions at the lumbosacral junction, that can also drive your, a change in your deformity, either sagittally or coronally. So here, the questions were, and I was going to pitch it to Chuck, any role or option for ALIF. he's not here, but based on the surgical history, I think this would fall into the contraindicated category. I would, even if he told me he'd probably try it, I'm not sure I would want to mess with that because his abdomen was a complete bomb. And then I wanted to ask you two and others in the audience, what are the posterior only operations for this patient for achieving fusion across a lumbosacral junction in the revision setting?
I think I don't do a lot of minimally invasive fusions, but I do revise quite a few. And I think there's not a lot of good dissection of the posterior elements. So you could see that they made a little hole and then they put the cage and bone in. So I think a thorough cleaning, removing the instrumentation, and doing facetectomies, and I think you should be able to get this fused. But I don't think that'll be the problem. The problem is the correction. So the 4-5 is asymmetrically collapsed, and he's got it's not as much the sagittal plane, but he has coronal and sagittal plane, right? So I think you can do this all from the back. I wouldn't go in the front. I would do from the back, and then you can do sort of an asymmetric PSO, not at 5, but at 4, and then get that corrected, depending on how far up you have to go. You don't have to go very high, just in the lumbar spine or the thoracolumbar junction down to the pelvis with iliac or S2AI screws.
Yeah, I agree. I don't think it'd be that complex to fix it up. You can work on the other disc side, on the whatever that is, the left, to do an interbody from that. Looks like the S1 screws may be a bit loose, so we would change and upsize those and improve the distal fixation. And then in terms of the realignment, as you can go up higher and realign them. I'm just not. I have to look at the imaging again whether I need a PSO at L4 or something to kind of an offset PSO to properly align him better.
Yeah. Yeah, it was nice that they didn't do anything on the contralateral side with the TP and the sacral ala. In the setting of an open operation where that's been attempted in the past, that would make it a more challenging situation. And maybe going on the contralateral disc, like you said, and putting a cage contralaterally, or considering taking out the old cage, I think would be under consideration. But here, because of that virgin side, we thought leaving the disc space alone would suffice.
So, I think that you should not take the urge of trying to take that cage out. Resist that urge.
Leave it, yeah.
Because when you go in the canal, there's nerves there. And, Art Steffi wrote a paper a long, long time ago where he had a lot of neurogenic problems, and it was always revision pliffs. So that scarring is real in the nerve root. You can really damage and traumatize the nerve root. So I would resist the urge of, unless it's really impinging on the nerve physically, I would resist the urge and try to just get the fusion, and you can get to the disc space from the other side, like Steve said, and then do your correction at L4.
Yeah, great. I think if there wasn't this significant abdominal history, we probably would consider all going to the front and taking out the cage and doing an anterior fusion for this. So what we did was revision, decompression, PCOs. At the L4-5 segment, I called it a T-lift, but what we did is we took an osteotome, broke that lateral osteophyte, did a discectomy, and then I just packed some cancellous graft in there. So I tried to release it bilaterally just to open it up. He had some other pretty significant comorbidities with his heart, so I thought PSO plus minus. And we did multiple rods across the lumbosacral junction, multiple pelvic screw fixation, and then on the right side we put a kickstand rod. Another intraoperative photo. Now you know where I got it from. So with him, I think this was the outcome, and the question is, do we restore the coronal plane adequately enough? And I think yes. His C7 plumb line is adequate. was a little bit concerned about pushing him too far the other way because you already see his right shoulder starting to come up, and maybe that's because he's not adequately corrected. But he's very happy with his improved posture. So.
Are you happy with like a hook on 11? A pretty small TP.
Yeah, I've only done that once, and this was it. And no, I was not happy. Yeah. I was toying around with different options and trying to figure out what I liked the most.
Well, I was telling somebody good judgment comes from experience and experience comes from bad judgment. So TPs of the thoracolumbar junction are no good.
Yeah.
So stick with the screws.
Yeah.
Upper thoracic TPs are much better, much stronger. You can actually lift the body off. But if you're within 2 centimeters, I mean, look at the coronal plane, it looks quite good. So I think you did a great job. Yeah.
Yeah, he's happy. Okay, great. So yeah, uneventful course. He went home relatively soon, and he's very happy. Oh, and then we got a CT post-op at 1 year just to see how things were looking. He was more curious about it than anything. And you can see posterior lateral fusion and interfacet fusion. That was the contralateral side. We were able to denude that cartilage. So thinking along the same lines. Okay, last case. And I think this is me presented by Rahul. Come on up.
Thank you. I have the unenviable task of being the last one. This patient was a 64-year-old female that had undergone multiple prior surgeries, as these things tend to go. Presented after feeling a pop in her back. This patient's history is notable for osteoporosis. Actually, had completed a full treatment with Forteo, as well as a couple other things that you see here. They have a kind of interesting cocktail pain pump that's also been implanted at some point by another physician. The surgical history is pretty extensive. As you see, it all started with the TLIF once upon a time. And then it sort of grew from an L4-5 TLIF that got removed and then turned into 2 laterals that were plated. And then at some other point, a 5-1 ALIF was done, and it became a T3 to pelvis fusion with the PSO. And then in 2018, the patient underwent a redo L5-S1 ALIF and revision of all screws between L4 and pelvis for what I understood to be pseudoarthrosis with multiple rod fractures and loose screws. This patient had presented with this exam when they were evaluated in our clinic, which I think was essentially stable from one of the 2 previous large surgeries that they had undergone. So they have some stable right-sided weakness with particular notable weakness of the TA and EHL on the right side. And that really hadn't changed for better or for worse in quite some time. You can see here a couple of notable things in the scoliosis film that we have, including the patient's still kind of relatively pitched forward sagittal alignment, sort of listing a little bit off to the right as well. There's an implanted pump. There's a few more notable things, which I think perhaps you can see more clearly up on the screen than back here, but this is what you can see how it looks in supine position compared to the upright position. You can also see here the theologist sign. So my slides were edited to include a bunch of red arrows that point out a couple of interesting phenomenon. But in summary, this patient has pseudoarthrosis. It looks like, I think this is the remnant of the 5-1 disc space, perhaps, that's like open. Here in the front, ventrally, at least one of these iliac screws is completely fractured, and there's a rod fracture as well. And you can see that most well demonstrated in the top right image there. So a question for the panel, in the context of revising what is a pretty complicated situation here, is a revision ALIF an option? And if so, from right or left side approach, given the patients had 2 prior. And if and when you attempt posterior reconstruction, what are your options for a number of rods and pelvic fixation?
Just a question. Do you guys use cannulated iliac screws? Is that a thing for you guys? Or? Because I see that these are cannulated ones. If they look...
The original operations were done
Okay.
many years ago. And
Okay.
I don't know if all their pelvic screws are cannulated or
Yeah.
not.
Okay. I don't use any cannulated for that. I just think they're weaker. But
Yeah.
so the clear distal fixation failure with a SUDA 5.1. The CT is not very clear. I think the options, you have some sagittal malalignment. I'd love to see a little bit better at the bottom there, what to do. But, that's obviously a contributing force. The simplest thing would be to reestablish some distal fixation into the pelvis, redo the iliac screws and set up perhaps a few more rods. And then I still think you have to address the 5.1 fusion, which I probably, with the previous anterior, would probably want to lean towards just doing the back again. And then this one I would throw in some BMP. And then I do get to use it for revisions. And then obviously if you have a non-union in the setting of a long construct, alignment is the issue. And a kyphotic lumbosacral junction is not a great recipe for fusion. And so that would be something I want to see if I can address it. I have to study the imaging a little better to see how I can do that better. So.
I think Steve said it eloquently, but it looks like there's disengagement of the screws and broken screws, and basically there's no distal fixation. That's why it's such a difference between standing and supine X-ray. In the supine X-ray, it looks quite well aligned. So I think reestablishing distal fixation, and then comes to see, look, it looks quite good there. I mean, you can see the view of the pelvis is in the correct plane, in the sagittal plane and the coronal plane. It's all lined up. So it's all the distal fixation issue. So I think you have to revise that completely. So one thing I wanted to confirm is there was a formal anterior approach at 5.1 before? Two of them, okay. I wouldn't go there because I've been there before. And I remember, I think one time I went to a 6th time anterior revision, and we put stents in, and then all of a sudden, like, what color is the stent? And of course, I was into the stent. So I think I would try to avoid a revision anterior. I would do it from the back, and then you'll have to do sort of a T-lift approach like Steve was saying, but adding good distal fixation, lining it up, and doing a T-lift from the back.
Yeah.
If it's a line, I'd have to study whether a trans 5 screw is another option for fixation as a kind of a salvage in these kind of.
So this is a integrated A-lift cage. So it's an A-lift cage that has a screw going down to S1. So how would you do the T-lift there? You take out the cage?
I would find out where the screws are and work around it.
Okay.
If how many screws are from the front? Are there?
I think it's one.
Usually there's like one, yeah. So I would work around it.
Okay.
And worse comes to worse, you put like they have these cortical made T-lift cages.
Mm-hmm.
So it's all bone. So you can put a couple of them around the screws.
Okay.
Yeah, but don't put BMP in there because the BMP tracks up into the canal. Yeah, but distal fixation is absolutely key.
So this patient was ultimately revised from L3 to the pelvis to address the distal fixation failure, as you pointed out, with an 8-rod construct. Which I think, as I understood, you didn't end up opening the whole incision to do a lot of this, or we were able to accomplish a lot of it through essentially the bottom half of the incision.
Yeah, so our thought process here was we were given the hard stop of another anterior by the vascular surgeons. He didn't want to go back in. We were thinking that, similar to what Dr. Gupta just said, that a lot of the sagittal plane deformity was just lack of pelvic fixation when he lay down. that his sagittal alignment got a lot better. So we thought just fuse him or re-instrument and essentially fuse him in situ. The question of how to get union across the 5-1 junction we weren't exactly sure. I like the idea of the screw. That probably what we would have done after the fact. So we decided to just load her up with a lot of rods and see how that went. The way that we connected additional rods is a construct that I use for when I do sacrectomies is with the distal iliac screws, we put a cross-link, a crossbar, a rod across it, and then we use that as an anchor point to have rods travel proximally. And so what we do is put a lateral connector that you use to the pelvic screws normally, connect that to a domino in line, and then run rods cranially. So that was a way that we could get rods, accessory rods to the lateral iliac screws. We could then go directly and then use that rod that goes transverse as other ways to go cranial. We did this about a year ago, and so far so good. But the question is, when will this fail? And it may not. I don't know.
Is that a transverse connector with the end-to-end connector on it?
Can I see that?
On the bottom, there's an end-to-end connector.
This way.
No, right, on the left. Yeah. That's an end-to-end connector.
Yeah, I think that's connected to. I don't know what that is.
You know, many years ago, we patented this technique where you put 2 iliac screws and put a rod across, and it has these connectors that go forward. And it was an idea to correct neuromuscular-pelvic obliquity. So once you have that rod, you can grab the rod and turn the pelvis how you want it. So Depute never made it, and then Globus copied it. So they produced it, but now Depue's making it again. So if you're ever in this situation, call up Depue, they have it.
Any comments from the audience? All right, well, that brings us to the end. Thank you, everybody, for staying. Hope you enjoyed the course, and thank you very much. Thanks, Steve.
All right.